So as far as ablation, so what is ablation? So why do we talk about ablative therapy? So ablation is not just destroying some tissue with some type of an energy source, but it also includes, it comes from amputation, excision, and surgical ablation. So we surgically ablate tumors when we excise them and remove them.
So I see, as many of you do, a lot of patients that have recurred after radiation therapy. And I'm now at Winthrop Hospital. We're a center of CyberKnife, if you listen to the radio. And it's a modality that we use for patients with low risk and intermediate risk prostate cancer.
I'll invite up Renee Sotelo. Renee Sotelo is going to talk to us about complications of ablation.
The overall complications is between 10 and 30%, but being clearly that 90% of that complications are minor, and most of them are early complications from the last series, and readmission are very, very low.
He had brought up these issues many years ago in terms of what are our strategies for low-risk patients. Is it going to be absence of cancer in follow-up, or is it going to be maintaining patients on a surveillance pathway and preventing them from crossing over to more aggressive strategies?
We give all of our patients the EPIC, the IEF, and the IPSS every 3 months when they come in, or it gets mailed to their home, and we compare it to patients that have had definitive therapy. And I'll show you our data, which is looking at total cryotherapy in the salvage setting, focal therapy, as well as patients that are on active surveillance.
If we cannot do a vesical urethral anastomosis, of course we need to do, the other option would be you can close the bladder neck, you can do appendical vesicostomy or Jank-Monty channel, but usually this patient will end in cystectomy and ileal conduit.